Well, I'm Daniel D'Amour. Thank you so much for joining us here at the Viz booth at International Stroke Conference. So I have a presentation that I would kind of like to pitch to you. And we're talking about best practices for stroke coordinators. Aaron and Cesar, I know you're both stroke coordinators. You're both certified advanced stroke coordinators, as a matter of fact, so congratulations on that. So I kind of really wanted to have that expert opinion from you. I'm going to share some of the things that we see nationally from stroke coordinators and see if some of the things resonate. Talk about maybe some of those roadblocks that you have and maybe how Viz has helped you either overcome them or give you another route for them.
Sure, sounds good.
So I created this myself. I love this. To me, this really is in a nutshell what our picture goal of what we should all be doing. So I'm curious, 30, 60, 90, does that resonate to you immediately? Is that something that you've heard before?
Absolutely.
Right?
Yes.
Because we're talking about, obviously, door to needle for thrombolytics is 30 minutes as a goal. And interestingly, it's not consistent throughout the country at 30 minutes. Some are still at 45 minutes, so I kind of wanted to see, you guys are at 30, right?
We are.
60 obviously for access, right? So whether you call that door to puncture or door to groin, it's the access. And then based on the target stroke phase 3 of door to device, it'll be 90 minutes for that first access, right? So you're welcome to use it.
Thank you.
I'll send it to you. And what I have here is a slide for you, so highlight your participation, which we, again, really appreciate. And I love this quote that your team came up with about how the Viz app has fundamentally changed everything, mainly about how you respond to stroke. Because that really is kind of the thing, is that we want to have that one platform, that one thing that gets us all together. And I love the way you just described that. And I love your pro tip, get everyone in your stroke world access to the app. So what does that mean? I know what it means to me. For me, as a former stroke program manager myself, it was always very important that everybody in a stroke program have the same resources. But it's funny because sometimes I see sites that are a little hesitant to have their CT techs on it, for instance, or maybe they don't see the benefit of having it in the IR team. The IR interventionalist, obviously, yes, but not the team kind of thing. How is it for access for you? You subscribe to the idea of having everybody involved, but were there kind of groups when you were first coming up that were like not quite sure they wanted to be on it?
Yeah, so our emergency room doctors, as well as some of the CT techs, as you mentioned, don't have direct access to the application, but how we've given them access is doing on-the-spot education. So it has brought the team closer. We communicate to them what the findings are based on the neurologist and neural interventionalist reviewing the examination on screen in real time, and it gives us an opportunity to do that real-time teaching and education. What are your thoughts about that?
Yeah, when we're in the scanner, oftentimes they're looking over our shoulders and they're like, what is that? What is that? And it gives us an opportunity to not only show them the functionality of the app, but then be able to do that on-the-spot education. With nursing, it's really great, to be able to pull up a CT, show them when there is a finding, what the finding is, and then talk about the exam and how it localizes to that finding. So it's a really great educational tool in real time.
And how that has changed the timeliness of our treatment is that people are more engaged, and right away the nurses in particular are acting, so what's the plan? What do you see on Viz? What should we do next? Are we ready to give the bolus?
So that's that flipping from being reactive to everything to being proactive, right? And
Absolutely.
I say this all the time, but it's rare that people really truly get that, but I can tell you do, that you're able to be just a completely different paradigm, a different mindset, which is awesome. I have this slide right here, so this is from Cooper University, and I wanted to highlight some of the things that that are special in the app here, and that is the ICH platform that we have. Do you all have ICH platform in your facility?
We do.
You do. So how has that, now I like to call the hemorrhagic program the redheaded stepchild of the stroke program, right? Because we all know this. Statistically, 87% of all strokes are ischemic, and that's where it gets all of the all the bells and whistles, right? All the resources. But the hemorrhagic ones are really the most lethal ones, right? So those are the ones that sometimes they don't even make it to the hospital. So how has having ICH impacted your hemorrhagic program?
It's been important in identifying the volume that they're dealing with.
Right.
Getting early conversation with our neurosurgery team. To determine what next steps needs to happen. So we're expediting care immediately from the emergency department CT scanner. Yeah,
and so much earlier than ever before, you're able to triage patients based on volume. I love that. That's a great concept. And right here, this is a fun one, right? So we tend to think, again, we tend to think of the platform as being most beneficial to the comprehensive centers. This is a feedback report from a hospital that is the primary center, and how quickly they were able to, never before see those images, see the fact that there was no blood on CT, all that kind of thing, to really increase parallel processes to drop their times. Now, 22 minutes for you all is probably, you might need to review that one, right? But for them, that was a record. So this is kind of one of those really cool things I'd like to see, that best practice of using the app. And what they did here is in the feedback, and actually inserted this image of BFAST in the app that you can do. You have that paperclip thing, you can click into that, put that in there. They inserted that into the app as a reminder to everyone, because this patient was identified as a posterior circulation stroke by the BFAST, so it was kind of like it was part of the education package. It was pretty cool.
That's great.
Okay, here we like to, so we're working on a hyperdense sign for the app, which is going to be very important, right? So again, not all facilities are going to have CT perfusion. Some of your freestanding EDs are just not going to have the ability to do that, so we want to have additional tools for that. So this is one of those ones. Again, I love the fact that in-app, the interventionalists are taking pictures pre and post angio, showing the clot, because everybody loves to see the final product, right? Well, how big was the clot? That's the first question that comes out. Now, do you find that your interventionalists using imaging and stuff like that in the app, in the communication?
They probably haven't as much as they should.
So it's probably a good opportunity for you to
Absolutely.
come back to your team and go, hey, we saw some really cool examples of, especially pre and post. Everybody loves to see that. Now, the nice thing about pre and post is that you can use that for your outreach, for EMS outreach. So we talk about, this is all about best practices, right? So EMS outreach, and I know how, Cesar, I know how involved you are in EMS outreach. These are those kinds of things that you can incorporate in the app. That way, picture saving a case that had great communication, pre and post, doing some EMS outreach, taking out your app and going, hey, this is how this works. This is how cool is this? And then to be able to share that with them. That'd be kind of neat, right?
Yes.
Awesome. And again, so this one, I know we talked about doing EMS outreach or like a Viz EMS kind of thing with using Viz Pager. Viz Pager is another what I would consider a best practice, just because of the fact that you really are truly getting in front of the patient. You're getting to the patient before the patient ever gets imaging. You're getting communication going on here. As you can see here in this Ocala Health one, this is really neat because they got advanced notification of a patient coming in. A stroke alert, 7 minutes ground. Now this is a while ago. You can see November 3rd, 2020. So what they're doing now is that they actually have a template for the information that's coming from EMS using those pre-hospital advanced stroke scales like RACE, FAST-ED, things like that, and then basically in a template information coming across as a page. So now before the patient ever gets there, you recognize that a right-sided weakness and a global aphasic patient is probably either a large bleed or a large vessel occlusion. You can turn around, kick in some parallel processes in your hospital so that they're waiting for that patient. Then you can really have that conversation about maybe even direct to CT angio, right? Maybe direct to the angio suite. Now, is that something you guys have talked about at all, going to angio directly based on clinical presentation?
Well, if
basically bypassing the ER?
Yes, I mean, we do have a process that exists that way, but not from the field.
Right.
So it would be from our transfers. So this would be a game changer of doing that from the field, instantly indicating the need to go direct to suite and avoiding ED stops. Yeah,
that's awesome. I mean, we think about it, right? So we have that clear clinical presentation communicated before the patient ever gets imaging. Really, you know, there are facilities that are looking at using the angio suite with a flat panel to do their non-contrast there instead of taking up time in the ER. So those, but it's so important, right? The EMS outreach that your clinical presentation is what you hope is actually is what you hope you're actually getting, right?
Yes.
Awesome. So now we talked about Viz Pager, and you had that Viz Pager conversation already. I just kind of wanted to this is all over the place, sorry about that. Viz Pager, it's a little slow. Viz Pager, we identified that the normal paging process is archaic. Actually, most of the time it's by radio. you talk about the telephone game, right? You're getting EMS information to the charge nurse, who's then calling a page operator. Page operator's entering something, and you get a page from an 80s drug dealer beeper, right? So that it still happens in a lot of places, believe it or not. So what we came up with, obviously, in a way to get past that, right? Use the technology, is to become a recipient of that page in the first place. And I know you all are in that conversation to be able to do that.
Yes.
It's actually very easy to accomplish. It's part of your LVO platform, all that kind of stuff. But we need to do a better job of getting that information out and what the value of that is in the pre-hospital. But not all facilities are as engaged in EMS as you all are, so sometimes that's a difficult conversation to have because it works the way it is, kind of thing. But really, this is a best practice, and we've had that conversation about how to get that to your facility and how to really maximize that. So we're talking about being able to now go from that to a communication where it is going directly. You're not having that radio communication. We're talking about having EMS being able to initiate that blast page from the app, and that would be really game changing, because now you're really getting, you're able to communicate, and you saw that communication even with Ocala, how the providers in the hospital are actually able to have bi-directional communication with the field team, even if it's through an intermediary like they're doing, where they're actually calling them back. Right. Saying, hey, I see that you're coming in with 7 minutes. Can you give me some information about the patient? And then they turn around and say, oh yeah, it's right-sided weakness, left gaze deviation. And they're like, whoa, that's a game changer. Hold on. When was the last time they used anticoagulants? Do you have a family number that we can go ahead and consult, and maybe even have a consenting process ahead of time while the patient's coming in? All of those things, of course, are parallel processes that can be game changing as well. So this is something that's very exciting. We consider this a best practice, and we see it already in the field. So we're very excited about having it come to you. This is what we're talking about, best practices, and Jamie Strauss, who's actually our Chief Clinical Officer, worked with me in this poster just a few years ago at ISC, showing how care plans and pathways will reduce length of stay. That was the principal thing, was the length of stay. Let me show you the key finding. Conclusion: workflow improves, reduce length of stay, reduce cost. Do you guys have a process in your hospital that is similar? Like, it basically, thinking of like a nursing care plan, right? But it's stroke specific, and it's metrics driven based on get with the guidelines and stuff like that. And the proof was the reduction in length of stay and savings. You all have that kind of process in there for your in-house patient, or not in-house, but admitted patients?
Yes, we do. Yeah.
So how long have you had that going on?
Probably prior to my joining of the team, I'd say over 5 years ago.
Yeah, so you're right ahead. You're right ahead of the curve, like Jamie was, in making sure that your teams have those kind of things. So, but we like to point these out in a presentation because not everybody has got there yet. Remember, nationally, not stroke care is not at one level, right? So it's about getting that word out to your other facilities as well. Even your outpatient or out of network sites. Now this one's a fun one. This is a feedback from my hometown of Jupiter, Florida, and they literally got this feedback report a couple days after going live. I gave a training for the interventionalist, forgot to take myself off call. that next day I'm walking my dog at 7:30 in the morning, and all of a sudden my phone goes off. I'm like, what is that? I'm not used to hearing my own, I know what it sounds like because I do the demo, but I'm not used to hearing it like for a real patient. And I was able to text the interventionalist, the stroke coordinator and everything, hey, did you guys see this? Oh yeah, we're on it, that kind of thing. This patient came in with a very short length of last seen normal kind of thing, and you can see that they got really good times. For them, it's not gold yet, but they're working on it. But more importantly, is you can see the communication, and I love how the fact that I trained the interventionalist to use the paperclip, and the very next patient he pulls up this one. Now the best part of this, have you ever watched the show Money Heist? In Spanish, it's I forget the name of it in Spanish. It's a Netflix show.
Yeah,
but the bank robbers wear Salvador Dali masks.
Okay.
Right? So I'm looking at this thing, I'm like, wow, this is something else, because this looks very familiar. And what I found was it looked just like the Salvador Dali mask. Now tell me, you are never going to be able to look at an AP of an angio AP like this ever again, right? Now, every time you see this, you'll see the mustache and the whole kind of thing of the middle cerebral artery and all that stuff. Isn't that fun?
That is great.
So this is kind of the end of my presentation here, but I did have the opportunity to pitch something for you. And I know you guys are involved in this, right? So I think as a best practice, we should all know about this. This is the American Association of Neurovascular Clinicians, right? And what is it? It's an agency, or it's not an agency.
Organization.
It's an association. It's an organization that has many focal points, right? So education, stuff like that. Certification is one of the big ones. So I gave you the props for being your advanced stroke certified already. But can you tell us a little bit about this organization? That I'm a member myself, by the way.
It's great. I actually happen to be the education chair for the board of the Association of Neurovascular Clinicians, and since becoming a member and now a member of the board, it is given an opportunity to open ties and communication with many neurovascular clinicians across the United States as well as internationally. What you have here is a consortium of providers, clinicians, nurses, advanced practice providers that get together and talk about what's active now in stroke care.
So cutting edge stuff.
Cutting edge stuff as far as our annual conferences and meetings. These certifications back up with the realistic goal of making sure that all of our nurses at the bedside and our clinicians are advancedly trained in knowing how to recognize the performance competencies that are necessary for, in this case, advanced stroke coordinator for maintaining a certification at your hospital. So the tools of our advanced stroke coordinator certification allows them to be experts in the key of managing a program, making sure they have all the facets of understanding education, the financial aspects of it, as well as the leadership qualities that you develop as a coordinator. So this is a great organization to be a part of.
And certification is so important for nursing. We recognize that to elevate our profession, we really do have to have every specialty should have its certification process and stuff like that. So I applaud your association for being the one to get there for neurovascular, certainly. And how was your experience with this, Erin?
Wonderful. So when I came on board, I began to study for and take the ASC. What I found really valuable is that it also includes kind of quality improvement and how to manage data and really how to drive your outcomes,
right?
Which you don't get in a purely clinical
certification. You have to learn that on the job, right?
Exactly.
And sometimes you're learning it from somebody that's not clinical, so there's definitely a miscommunication. Stroke coordinators, we know, have the hardest job there is, if you ask me. I was an ED clinical educator, which was kind of second, but we recognize how difficult a job it is and stuff like that. So to have an association that backs you up with data, education, all that kind of stuff is fantastic. So I have a slide that, for everybody that I'm going to share this deck with is how to join the association and stuff like that. So I think it's very important that we get the word out as a best practice to get certified, all that kind of stuff. So I did want to go through, now Michelle Whaley was so kind to go and really, she had a recent class of ASC certified nurses and asked about best practices in their facilities and stuff like that. So she was kind enough she did all the legwork for me, so I'm going to give her all the credit. She provides slides that gives us that kind of idea. Now, right away, we talked about this EMS engagement, right? And as you can tell, I really perk up with EMS because I think it's so important for us to have that communication pre-hospital in order to, it's kind of self-serving. It's better for us when we have a better presentation, but then again, it's better for them as well because it's their patients as well. And we don't always think of them that way, like they really care about their patients, but they do. My son's a paramedic. He talks about his patients all the time, which I think is fantastic. So it's kind of it's a two-way thing for us to be able to have outreach, right? So that's a great point there. And then we have Elizabeth Gilbert, best practice tip. Stakeholders participate in new process, and we talked about this quality improvement and all that kind of stuff. So it's very important to have everybody engaged. I like this one. This is facilitating rapid initial and then the VAN assessment. So I remember a conversation with you about EMS scales and stuff like that, and you don't all use a consistent one with your providers, right, for EMS? Or is that they have kind of come together for one scale?
Yeah, for the state of Pennsylvania where we service and our hospital is located, the RACE score has been highly recommended but is not a requirement. So you're still going to have EMS paramedics will make the decision in the field as to use it. So the training the aspect of using it regularly can sometimes be questionable. So we try really hard to also, as an organization, when we give feedback, to allow opportunity to give them also education that might help them raise their game.
Yeah, absolutely. So for them to be able to identify a stroke is not a stroke is not a stroke, that there are levels of stroke that you really, it's kind of like with the heart attack, right? We think about that in STEMI. EMS understands STEMI very well. A STEMI care is probably 10 years ahead of stroke. STEMI and large vessel occlusion being that same kind of heightened awareness for the treatment options that you have, right? So it's very important to reach out to them. Thanks for sharing that. And then here we have one from Kaiser Permanente. This is great. Best practice is rapid response teams, right? So for all stroke alerts to have a dedicated team. So again, going back to the STEMI model, that has been a team approach for a long time. And then even before then, think about your Code Blue assignment. So here's a question I'm going to have for you about that, thinking in that same path. In my hospitals, when I worked in the ER, we always had designated assignments in our ER nursing, right? So I knew if I came in, I'm getting bed 1 through 4, plus I'm the medication nurse for any Code Blue, right? That's an additional assignment. I just know if I hear Code Blue, I go to the cart, I'm pulling out medication. I don't have to worry about compressions, I have a role. Do you do something like that in your ERs, in your for stroke responses? Something like that?
Do you want to tell them a little bit about the float nurse and their role?
Yeah, so we have 2 nurses that respond to brain attacks as they come in through the emergency department. We have a float nurse and then the primary nurse who will ultimately be taking that patient. And then they have a designated set of jobs that they do when the patient comes in. So one of those nurses is on the patient, starting lines, really like hands-on on the patient. The other nurse is taking report from EMS. They're starting the documentation process. And then when we're in-house, we respond as well. And we try to kind of like act as
facilitate.
Yeah,
sure. Facilitate, yeah.
So I can't necessarily speak to the way that the assignments are built in the emergency department because I was never an ED nurse in our department, but that's how we have built them into the brain attack process.
Great. So how important it is to have predefined roles and responsibilities.
Absolutely.
So you have an idea of where you're going. It's a chaotic situation. We want to have as much clarity as possible. So that's a great practice. And again, a best practice, right? Developing strong relationships with the stroke team is key, obviously. So this is about that whole making sure that everybody is engaged in your process, and really it doesn't matter what the disease process is. In stroke, obviously we're in International Stroke Conference now, so we're focusing on stroke, but we know that these teams and these theories are all work for every disease process, especially everything that has hyperacute. We've got, we have FDA algorithms now for PE, aortic disease. We know we have the LVO, ICH, and many more along the way. We have aneurysm that's 510K pending, all those kind of things. So these disease processes with that hyperactivity, the hyperacuity at the up front is very important to tackle, right? Okay, and I love this one, right? Utilize the 3 E's: engage, educate, empower. So talk to me about, we know you know the education, talk to me about how you empower people with that education.
Specifically with using the application or just understanding the stroke?
That would be great, yeah.
So we empower, for instance, our residents in training. We have residents that come in every year that we do onboarding, and we introduce
You gotta love your July 1st, right?
Exactly, but what we like to do is we bring out the toys, right? So Viz.ai has been an application that we use as part of our onboarding education, helping them understand that this is a tool, an extension to your practice.
Right.
It does not replace the clinical judgment, but it is a tool that is effective and also increases your way of communicating with the provider you're attending, who may be on call or not on site, or maybe with another patient in the in-house setting. So we found that helps them empower understanding leadership, ways of communicating within their team, but then also that on-the-spot education that they deliver to the nurses in the emergency department as well as in the ICU, when they kind of do a little debriefing about a brain attack that has just occurred. Look, this is what we saw in imaging. This application is helping us decide, and this is why we're going in for intervention, or we've given them T&K for that reason.
That's awesome.
We empower our nurses. Anybody can call a brain attack. You do not need to talk to a
physician that's
physician
fantastic.
first. And I feel like when you're able to give them that on-the-spot education, they just feel more comfortable, then they feel more empowered, and they're more likely to be like steadfast in their decision to call a brain attack.
And education is the key to all of that, right?
Absolutely.
So you're not going to feel empowered. You're going to be a little shy if you're not confident, if you haven't been trained and you don't practice,
Right.
So those are great points. And I believe I have a few more here, right? Become a large presence in nursing units. So this is huge, right? So tell me about your process. What have you done recently with maybe with the app, if you could speak something to that, for your in-house stroke patients, which again, talking about redheaded stepchildren, right? We know that in-house stroke alerts are more difficult, and they kind of, it's kind of the Achilles heel of national stroke care is in-house stroke alerts. Have you done anything differently with the app to be able to assist with that?
So I think I can answer to that. Very similar to how we have a brain attack process in the emergency department, we know that inpatient brain attacks don't happen as often, but we've given the nurses the autonomy to activate based on symptomology that they identified as being neurological change.
Right.
Once they do that, we encourage that primary or bedside nurse to not only hand off report to the responding team, but to come with us down to the CT imaging. And as we're there, we pull out the app and we reference and we start doing the education. We allow them to see on the other side what may have happened potentially to this patient had they walked through the emergency department. And understanding all this process, that the electronic application, the technology that we're using, the advanced care that we deliver is why we are ranked highly in our area for that reason. And so they have this pride that they associate it with, and then they learn about it.
Right.
And what do? They transcend and kind of cross-pollinate and share that with their peers on the floor, that every time there's some brain attack activation in the inpatient setting, they all want to go.
Oh, sure.
They all want to have an understanding what's happening.
Exactly. And again, that's the confidence, right?
And they want the follow-up afterwards. They'll see us in the hallway and be like, hey, wait a minute.
Right.
Let me see
what
that
happened?
picture. I want to show Joanne this image. You got to see this.
That's great.
So it's exciting.
Well, so your teammate Alicia Richardson had a great quote, how you use the mobile app to train on the fly, which I think is, that's a great way to put it, right? So I actually pictured, I was looking for like images and stuff. I pictured somebody literally running with like a laptop, right? Because you have that mobility. You've got that mobility. Of course, luckily it's in your hand and you don't have to hold it out in front of you. But the whole idea of training on the fly, I think, is huge. So I love that quote. And I've got a personal resources for success here. I love this. This is from Rhonda Finney. Know yourself, right? These are personal resources. This is a very challenging career field with a lot of challenges. Not just challenging, but there are a lot of challenges for us. So this is one of those great things to be able to look at like introspectively, because you take care of yourself, you'll be able to take care of your patients better, right? So I think that those are great points here. Communication connection, and we know how important communication and dashboards are. So tell me, Aaron, what do you use? What kind of dashboards do you use to relay the information of those trends of, whether it's an upward or downward trend? How do you relay your information with dashboards? Do you use anything like Viz Analytics, or do you use anything that we provide you for reports or feedback in your dashboards?
So we have not. Currently, our dashboards are homegrown.
Yep.
And we actually just changed visually what ours looks like to be more of kind of like a red-green report. So you can see right away. Here's where we need to focus.
Throw in some yellow there because you're about to turn red.
Right.
That's right. Caution.
So Caesar and I both have a background in graphic design, so we're both very visual people.
Nice.
So the more that we can make something visual and bring that back to our stakeholders, I think that's one of our goals is doing the best that we can with that. And so any opportunity that we have to involve more data visually into what we present, we're happy to go with that.
Awesome. Well, we'll line you up with your customer success manager to really look into the opportunities that we have for automated reports for you, as well as you having access to Viz Analytics at your fingertips. And I believe this is our next to the last one, right? So I have ICU stroke response. Again, we talked about this. A lot of ICU float nurses are your stroke responders, both in-house and even to the ER, depending on the size of the facility. I would imagine yours is probably too big to have ICU nurses responding to like ER stroke alerts, right? What is the constitution of your response teams in the ER? Are they all ER nurses, or do you have a combination of skill sets?
So in the emergency department, we do have a combination of a core group of emergency nurses, but we also have critically care trained nurses that float.
Oh yeah,
that will potentially work in the emergency department, but also in the ICU. It's given us an advantage, especially with COVID, the impact of COVID, bringing some of those critical care nurses down to the emergency department when we've had maybe delays in admission or post-procedure or post-treatment where they require that quick assessment, that ongoing serial assessment to make sure that there's no neurological decline missed. And all of them have had some sort of neurological ICU training.
That's awesome.
For the inpatient setting, I think you can speak to that the responding nurses are typically...
The neurocritical care charge nurse comes to that. And then we have nurse resource coordinators who are kind of like your like rapid response nurses
Sure.
throughout the whole system. And they work together really well. If we're giving TNK, the NCCU charge nurse is responsible for that piece of it. And it's just a really great integration, I think, across the hospital of having the right people coming to our inpatient brain attacks.
And again, those are best practices. I'm sure you've been commended for them during surveys and stuff like that about your dedicated roles and stuff. Plus the fact that you have ICU trained and neuro ICU trained is just, it's the way to go, right? To really up your game. And then, so I'm going to share 2 slides with you. I'm going to share that 30, 60, 90 with you, and I'm going to share this last one here. This one brings us to the why. Why do we do what we do? I had this slide prepared for a talk that I gave at the Florida Puerto Rico Registry for stroke disparities, and it was early on in the process, and we sometimes have to just step back and remember why we're doing what we do. I like to think of it as being that impact to difference between walking out and wheeling out or being wheeled out, right? Feeding yourself versus being fed. Right. And I love this one, visiting versus being visited. Mm-hmm. Right? So you kind of like share this with your team every once in a while, to remind yourselves, you know what, yeah, it's a tough job, but it's definitely worth it, and we are making an impact. So I want to thank you for spending your time with me, pulling you out of sessions here to share your best practices, and I really appreciate your contributions.
Thank you for having us, Daniel.
Awesome, thanks.